We have the honor of welcoming Dr. Nancy Santesso today, who is an assistant professor in the Department of Health Research Methods, Evidence and Impact, and the Deputy Director of Cochrane Canada. So thank you for joining us, Nancy.
Great, thank you. So I'll just get started then, is that okay?
Yeah, I think that sounds great, actually.
Okay, good. So today I was asked to speak a little bit about how to communicate the results of a systematic review in simple statements. I'm hoping to cover a few things as I go along. First of all, just wanted to emphasize why it is important when we are communicating the results of our systematic review that we also include some indicators of how certain we are in those results. And then how potentially could we present those and communicate those results, how people are currently doing it, and ways that we might improve that way of doing it. Then discuss a little bit of work and research that we did, and then describe a little bit about the system that we created. This work obviously is based on a lot of work from a lot of people, and I just have at the end of the presentation the link to the article and some other information about what we've done here. And
yes. mention too that I think that maybe for the people that just joined, please put your questions in the chat, and I believe Nancy will be taking questions midway.
Yes, absolutely. So halfway through, I'm happy to stop and see if there's anything that we need to clarify with before we go on. Okay, so why is it important to communicate when we have the results of a systematic review? Not only do we communicate, the effects that we found on the outcomes, but how it is important to also communicate how certain we are about the results. And I typically use an example like this, where this one is, say you've conducted a systematic review about providing vaccines with people in COPD. And just to let you know that I've made up this data, it's not necessarily from a real systematic review. But obviously, you would have gone through and you identified some important outcomes, such as pneumonia and infections, quality of life, and possibly GI events from the vaccine. You pulled together the evidence from some from the studies, and then you came up with your relative effects or mean differences and, translated into numbers of people. We actually found that there were 100 fewer pneumonia if you do the calculations if you take vaccines, 75 more minor infections. Quality of life, if you had the vaccine, would have gone down by 10 points. And GI events, which needed some follow-up treatment, went up by 100 events. And so you, in essence, could just provide these numbers, and that's what's typically been done. Here's our systematic review, and here's what we found, and these are the effects. But we know if people had to start making decisions about whether the benefits outweigh the harms. So you could potentially just look at, oh, there's 100 fewer pneumonia, but we have some minor infections. It looks like we have a few more GI events, and start to balance those benefits and harms. But if we were to tell you how confident we were in those numbers, how certain we were in those numbers. If I was to tell you that after I did my systematic review, I assessed the evidence that came from that systematic review, and I found out that actually, I came up with a number of 100 fewer pneumonia, but I'm not really certain about it, that I have low certainty in those numbers. But I have high certainty and moderate certainty in the harms that potentially are happening when people take those vaccines. And so if I had to balance those benefits and harms, I may actually be sitting on the fence here and saying, well, I'm not sure about the benefits. I have low certainty in those benefits. And those benefits may not outweigh my certainty in those harms. And so that certainty of evidence could help inform the decisions. And then, I could flip it and say, well, actually, when I did my review, I came out and I found that I actually have high certainty in those number of fewer pneumonias, and I have lower certainty in those harms. And so then your interpretation and possibly when you're making your decisions, I'm certain about the benefits and I'm uncertain about these harms. And hopefully I've shown that really decisions will be also dependent not just on those numbers, but on how certain you are about those numbers. And so we need to communicate that to anyone who's making decisions based on your systematic review. And you know, I'm a member of the GRADE working group, and working with the GRADE working group and working with Cochrane systematic reviews, the GRADE approach is one of the ways that you can assess the certainty of the evidence. And I'm not going to spend time going through how to grade that evidence or come up with those levels of certainty, but only to say that there are specific criteria that we say that should be used when you're assessing the evidence. So risk of bias, inconsistency of those results, the indirectness, the applicability of that question and the results that you found, imprecision, how many people were in the results in the statistical analysis or in your narrative synthesis. Are we possibly missing some studies? And if you're working with non-randomized studies, you would also consider whether you're finding large effects from the studies, a dose-response relationship, or opposing confounding. So all of these will feed into your assessment of the certainty in the evidence. And that's how you would come up with these different levels of certainty. And so in GRADE, we have 4 levels of certainty, and each level of certainty depends on and describes how confident you are in those results. So if you have high certainty, you're very confident that the effect that you found in your review lies close to the true effect. But as we go down in our level of certainty, we become moderately confident in the results. Low certainty, we have limited confidence in our results. And very low certainty, we have very little confidence in the results that we found from our systematic review for that outcome actually reflecting the true effect. So that's a really brief description of why it's important to look at the certainty of evidence and why it is important that we also communicate the certainty of the evidence. So the next question is how should we then present our certainty in the effect so that decision makers can use it in decision making? And basically, we could, in essence, just follow and present it in a table where we have the outcomes, similar to the table I just showed you with the pneumonia and vaccines example. We have all of the outcomes listed in the table. We have the effects that we found from the systematic review. And then we also have our certainty of the evidence. And if you've used and created any of these tables, if you've done a Cochrane systematic review, it's a basic summary of findings table. It just makes it easier for decision makers to see what the evidence is for each of your outcomes. What we did do is we did a little bit of research to see how these tables are go over, whether they're useful and have been used. And it's been studied for many, many times. But recently, when we did one of the randomized control trials in these tables, what we found was that not only do people like to see that summary of findings there, they also would like to have you can see it on that very last column, they also want to see a summary statement describing what happens. So it wasn't enough to simply show, here's pneumonia, here's the relative effect that we found, a risk ratio of 0.84, and this is how certain we are about it, and this is what will happen to people. They also wanted a summary statement to help them interpret that evidence. And so then, that is really pushing us to say, okay, how could we write these summary statements in these tables? We also know that in systematic reviews and in any summaries, that we would like to communicate not just in a table, the numbers and the certainty of evidence, but put it narratively when we're communicating results. So you could include it in your abstract, results section, discussion, or plain language summaries, any type of summary statement, and authors obviously are doing this. And also in any product that we would want to create to communicate the results of our systematic review to many different target audiences, whether it's through the media, guideline developers who are looking at our reviews and using that to make recommendations, policymakers who need to look at this evidence to make decisions at a policy level, and any other decision maker. So we did look at how people are communicating results currently from their systematic reviews. And what we found was that people are being awfully creative with how they're communicating their results. And I just listed a couple of examples here that, and this one was pulled out of, I've hidden the outcome and the intervention just so it's not obvious, but this, this first statement, this is something that someone had communicated in their systematic review. The evidence for the outcome shows, at best, a non-statistically significant trend in favor of the treatment. And so for a decision maker, this is likely quite confusing to interpret and understand what is being communicated here. We also know that people are communicating evidence of no effect or no evidence of effect in different ways. It's being interpreted in different ways. And so we're seeing a lot of statements that are just confusing to decision makers. We also see that there are some misleading statements or statements that are not quite correct and being communicated in abstracts and conclusions. We can see, in the conclusions, and this isn't necessarily pulled from a specific abstract, but we do say that this happens. In the conclusions or the abstract, they'll say, oh, well, this treatment reduces mortality. Sounds like a very strong statement, but in actuality, when you look at the review, you'll see that the evidence that was supporting this statement or effect was actually based on low certainty. So should we really be communicating that this treatment does indeed reduce mortality? And then the other problems that we're seeing is that people are communicating something like there's no effect on mortality. And yes, it's based on low certainty evidence, but that decision or that conclusion that there's no effect on mortality is based on an effect that was not statistically significant. And I just wanted to focus a few more minutes on this last statement here, which is creating a lot of misunderstanding in the public and anyone reading systematic reviews. Unfortunately, we see that when something is not statistically significant, people are incorrectly interpreting this as meaning that there is no effect on mortality. And so this can be quite dangerous as well. And so I'll just give an example of, and a little bit of a side story, but a little bit of an example of how it can be quite misleading to be making these conclusions that there's no effect. This is an example of a forest plot showing the analysis from heparin versus placebo in patients who have cancer. And the outcome was minor bleeding. What you can see is that the risk for minor bleeding in people, the risk ratio was 1.34, and the confidence intervals went from 0.84 to 2.14. It is indeed not statistically significant, but does it actually mean that there is no effect? And if you grade the certainty of the evidence, you may make the conclusion that the confidence intervals are wide due to the few events in the people in the studies, but should we be actually saying that this means that heparin actually has no effect on bleeds? There has been quite a bit of information being, explored and put out there and published about how we're misinterpreting confidence intervals and the p-values. This, was the statement from the American Statistical Association, where, and I'll just read out that bottom statement there, where the p-value was never intended to be a substitute for scientific reasoning. Well-reasoned statistical arguments contain much more than the value of a single number and whether that number exceeds an arbitrary threshold. And so the ASA statement is putting out statements to move people away from using this p-value of 0.015 or the confidence intervals to determine whether something has an effect or not. And some of the key statements were, p-values do not measure the probability that the studied hypothesis is true or that the probability of the data were produced by random chance alone. And in particular, in number 5, the p-value or the statistical significance does not measure the size of an effect or the importance of the result. And just to make this even more clear, also from published in the Nature series, is that there is a problem and that they're seeing that people are interpreting not statistically significant effects incorrectly. And then it's saying that let's be clear about what must stop. We should never conclude that there is no difference or no association just because the p-value is larger than a threshold such as 0.05, or because the confidence interval includes 0. We shouldn't conclude that studies conflict because one's statistically significant and one is not, and it's indeed an error. So really what we are saying is that just because a confidence interval is wide and includes no effect, that it's not statistically significant, does not mean that there is no effect. And back in 2005, some work from Doug Altman, same message coming through. The confidence intervals really represent a range of values, and it is often, and it's a common serious mistake to conclude that something that is non-significant results, that the groups are the same, and that there's no effect or that there's no difference. So just to emphasize that, unfortunately, what we are finding is that authors are interpreting these confidence intervals to mean that there is no effect. And so, again, what we've come up with is maybe we need to develop a different way to communicate results. One part of it is not focusing on statistical significance, but instead focusing on the effect and the certainty of the evidence instead. So we've come up with a better way to communicate the results. Now I'm just thinking if there are any questions so far, just to see how we're doing.
There's like 3 questions.
Okay, maybe I can, oops, I stopped shared. Let me just make sure we share that, and I'll just make sure I go back to the screen and the chat. Sure.
So the first one is by Candace, and she asks, why does very low certainty mean it's substantially different? Could it not be similar, but you just aren't sure?
Sure. So let me go back to that slide, because I think we're probably about here in the very low certainty. Yes. So basically what we're saying is if we look at the high certainty, we're very confident that, so that effect, that risk ratio of 0.84, for example, if we have high certainty, we're sure, we're very confident that that 0.84, that reduction of 16%, is really close to, that's the true effect. It's really close to what we think is the true effect. Whereas if we get to, as we go down the bottom, so for very low certainty or very low confidence, that effect that we found, that 0.84, it's probably, the true effect is probably very different from that 0.84 because we have very low confidence in that effect. And whether it's due to risk of bias in the studies or imprecision, not a lot of people in the studies, and any of those other factors of grade, that's why we would say that. Hope that sort of made it clear.
Yeah, I think maybe, I don't know if people have problems with thinking about true effect, but, you know, when you have, if you have all of this bias or, you know, maybe it's imprecision, whatever it may be, some problem with the data, then your effect estimate may be overinflated or underinflated.
Yeah, and it could be due to any of these reasons. It's, you know, it's not just risk of bias, it's a whole bias in that result. Yeah, absolutely.
Okay, so Aaron has another question too here. So he asks, for your creative examples, how did you get through an editorial review? Is it not a joint responsibility, i.e. authors and editorial team? And then he asks us, I'll let you go.
Yeah, sure, and that it does, and, you know, and you could probably pop into any journal or any systematic review, and you will see these creative ways of communicating, and sometimes, and actually, I have to say that, you know, I submitted something to a reputable journal, and they came back to me because they didn't think, they wanted me to actually say that there was no effect. Because it crossed the confidence interval. And I had to argue back with them and actually show them the work from the ASA, from Nature, the work that we're doing within grade, to say, you know, no, that's not the correct interpretation. So I actually wouldn't rely on the the reviewers or the editors to actually be clear. And part of that Nature series and the ASA is to push for editorial, and we know that even in editorial groups that they're saying, you know, the most important thing to communicate are the confidence intervals, not necessarily this p-value.
Great. So, did you want to read it, Michelle?
Sure. So Michelle, please comment on the reporting of effect size, especially when the active placebo effect is added to the treatment arm to reflect an overall and significant effect. I'm afraid I'm not sure. Maybe, Michelle, if you're able to speak, if you're not on mute.
Hi.
Hi, yes, we hear.
Oh, good, you can hear me, great. Apparently, the effect size is used in meta-analysis, for example, to group together unrelated measures and come up with an overall effect size. And what some people are doing, they're taking the effect size of a placebo when that placebo is like an active placebo and saying, well, the treatment arm, although the difference between the active placebo and the treatment arm is not statistically significant, if you look at the overall effect size of the treatment arm, it's clinically significant. And it just becomes confusing as how to interpret when the effect size is actually computed properly to come up with that conclusion in a meta-analysis.
Yes, I'm hoping, and I hope if I understood correctly, and I know that we do, especially when we're teaching about, you know, just in general about systematic reviews, many times people will focus on the statistical significance, again, of the individual studies. And we do always argue that people shouldn't be focusing too much on the individual studies, likely because there's not enough power in those small studies. And the reason we do a meta-analysis is actually to try to bring all those people and to add them all up to have more power at the end. So if I understand correctly, you know, the effect size, some people will focus on the effect size of the individual studies, but in actuality, in a meta-analysis, we should focus on that last diamond and make conclusions based on that last, you know, that effect size, and how certain we are about that final effect size. I hope I've answered okay.
Yes, that helps a lot. Thank you very much.
Good. And then another comment from Zhang. When my group did a systematic review regarding the relationship between alcohol consumption and pregnancy, we pulled the pooled overall estimates, which was not statistically significant, but when we did the subgroup analysis, revealed positive associations, not statistically. I'm wondering how we make the conclusion. I think the main point is still, I can still say that we shouldn't be focusing on statistical significance and making conclusions based on statistical significance. And, you know, we should be instead looking at, you know, how much power do we have? what's the risk of bias, and then making a conclusion based on the certainty of the evidence that we have, and then the effect that we found. And Na-Zheng, if you can wait to the end, I'll show you how we are saying that this could be done, and maybe that'll help to answer your question, I hope.
So Laura also asks, are those descriptions for the level of certainty considered plain language, or is there a system of stating those levels in a more lay audience?
Right. So we'll get to that, and I'll tell you exactly how we developed our statements. You'll see it all started when we were trying to communicate the results of systematic reviews to consumers and a lay audience. Maybe we'll go ahead, and then we'll save some questions for the end.
Okay, sounds great, Nancy.
Seems like I'm going to get to it. Okay, good. That's a good sign. Okay, so how are they currently? So what could be a better way of actually communicating the evidence? So we had some ideas, and we came up finally, after quite a few years, we came up finally with a standard list of statements at the end. And I will go through these. But just to say that this standard list of statements is based on two concepts. So we came up with statements if you can pull together the size of the effect, so how big is the effect, and how certain are we in that effect. And then we pulled those two together to come up with one statement. And there are a variety of statements. The easy part was, okay, when we're talking about certainty, let's just use what grade decides is high certainty, moderate certainty, low certainty, and very low certainty. But we also said that this system that we've come up with could equally apply to any other system that provides levels of certainty. And even better if that system also has 4 levels, because then it could map on really well. But this type of system could work with any other system that uses different levels of certainty. The more difficult part is asking authors to think about how big is an effect. It was a bit tougher, and we had to start thinking of a different system to come up with how big is an effect. And so one of the things is, did we just make this up? And I think this will lead to that question about, how did this come about? Are these for consumers or not? So there was a lot of work in quite a few groups in Cochrane. Started, way back in the 2000s, early 2000s. And the funny thing was, went to a meeting, Cochrane Colloquium meeting, and a lot of people were talking about it, doing little presentations about it. And so many of us got together and said, okay, listen, we're all struggling with this, how to communicate the results of our reviews. And in particular, we were struggling with how to communicate it to consumers and within the plain language summaries in Cochrane systematic reviews. So based on that, quite a bit of work was being done. We conducted some focus groups in people in different groups across the world, which eventually led to a randomized control trial about how these statements were communicated. But let me first focus on, how we make some decisions about the size of the effects. Because again, there are two concepts. One is about the certainty, and one is about the size of the effect. So the first way that we were thinking about communicating the size of the effect is if we said to authors, you need to think about what is an important effect or an important difference. You need to also think about what would be small, that might be a small increase or a small decrease in death. And then you need to think about what would be something that you would say, oh, that's negligible. There's really no important difference at all. So we said, let's just categorize it into 3 ways: an important difference, something small, and nothing. And we started out that way. And then we started talking to people. And then it turned out that they wanted to have a little bit more granularity, I guess I could say, about how to decide. And so then we came up with, well, we could talk about important benefits and harms, or we could talk about important benefits and harms and whether the confidence intervals cross over into a harm, they crossed the line of no effect, they crossed the harm of an important effect, and then we started getting into how wide our confidence intervals were. And you can see, then we went to less important difference. So we had an important difference, a less important difference. Then it depended on there was no important difference, and then it was dependent on how wide the confidence intervals were and whether they included null effects. So it's two ways, the point estimate from our systematic review and then the confidence intervals. But then we realized that actually making decisions based on the width of the confidence interval is already covered when we talk about the certainty of the evidence. So we would almost be double counting or double penalizing something based on the confidence interval. So we said, you know what, we need to focus on the size of the effect separately and the certainty of the evidence. And I'll just kind of go through a little bit of maybe just to clarify what we mean here. If you've ever done grade or even used a different system of assessing the certainty of the evidence, one of the ways to assess the evidence is to consider whether the results are imprecise, whether there are enough events, enough people in the analysis, and then also whether the confidence intervals are really wide. So those are the two criteria we use in grade to assess how certain we are in the evidence. So again, we're back to certainty of evidence. If we were to plot our diamond here, this is our effect. Really, this effect is showing that, whatever the outcome, so say if we went back to our vaccines or even the heparin example, if we said that heparin is actually, reducing the number of bleeds, or, or maybe we should say vaccines, if we're reducing our number of bleeds by 10, for example, that would actually fall into an effect between a small benefit and a moderate benefit, or just a benefit. The confidence intervals are really wide from what we found, that actually there's the possibility that within that confidence interval, there's a possibility that this intervention could have a large effect. There's also the possibility that it could have a small benefit or no benefit at all, for example. And so when we assess the certainty of our evidence and imprecision, when we get something that looks like this, where it's crossing over and the confidence intervals include chances of benefit, small benefit, no benefit, and large benefit, in those cases, that's when we would rate down for imprecision. And that's part of the decision-making process, because people always ask, well, how wide is a wide confidence interval? Well, a wide confidence interval happens when it's actually going into all these other areas of actual benefit or no benefit, etc. And so this is, again, taken into consideration in the assessment of the imprecision in grade. But we still wanted to focus on how big is the effect. And that part was actually about the certainty in the effect. So what we did come up with just to begin with, and early, this was back in, you'll see when we published in 2010, the system of how to come up with how to communicate results. So across the top, we just divided it up into important benefit, a less important benefit, and no important benefit. So that was back in 2010 when we were developing it. And we came up with how we could communicate these statements. And you can see, you can go along the top for the size of the effect, and then along the left-hand side, you would go along and determine what your certainty in the evidence was. And basically what it amounted to was the proposed statements in 2014 when they came out was that we would have the intervention will improve, the intervention probably improves, the intervention may improve, and we are uncertain. And so those coincided with high certainty, moderate certainty, low certainty, and very low certainty. And then if it turned out that you had a less important benefit, it was small, you could add in the term slightly. So you could say, if I have low certainty in the evidence, I would say the intervention may improve the outcome slightly, for example. So we just had these very basic proposed statements that were available that we put forward. But what happened after a lot of informal feedback, work from workshops, and when we were training, that people were finding that these statements were quite monotonous, and they wanted more options about how to communicate it. And then some people were just not comfortable using the words, for example, probably. Didn't sound scientific enough. But we did, when we did our testing, these were well understood by consumers and lay audiences, by guideline developers, etc. So they were well received and well understood. It's just authors wanted something a little bit more, more choices when they were communicating their results. So because of this, not too long ago, we started trying to look for other ways that could be, the evidence could be communicated, other wording options. We did multiple workshops with multiple people about some, ways that they were using to communicate and ways to improve the communication. And then we conducted a survey with users of systematic reviews, developers of guidelines, and systematic reviews as well. And what we heard from them was that, we heard some feedback about the statements. One funny thing that happened was we had one of our statements that we had put forward was, oh, maybe we should say it appears that something has this effect. And so we just even, in casual, just kind of a funny thing that happened. It was like, appears isn't probably a good word, sounds a little bit too supernatural. So we'll, you need to think of a better statement than that. In any case, we came up with a statement, and you saw that large sort of table that we had. So now we have available more options that people can use, and the way to use the system is the same way. First, you would focus on the certainty of the evidence. So I've done my systematic review, I have my results, I now assess my certainty of the evidence, and I've ended up with high certainty evidence. And your choices could be that you would just say right out, there's no qualifying words necessary, intervention results in, intervention reduces this outcome, etc. And so you would be very straightforward, it reduces mortality, for example, if you have high certainty evidence, because there's no doubt about it. If you had moderate certainty evidence, we have some qualifying words. So the intervention likely results in, or the intervention probably results in, or leads to something. And so you'll notice all of this wording, no matter what your effect is, or how large you think the effect is, you will use words such as likely or probably. And so those are some options. If you find that your evidence is low certainty, you would find that you would say, oh, X may, the intervention may result in, or the evidence suggests that X, the intervention results in. So the qualifying words there are may and evidence suggests. And then if you end up with very low certainty evidence, you'll be using words such as the evidence is very uncertain about this effect on this outcome, or X may reduce this outcome or increase this outcome, but the evidence is uncertain. So those are the types of qualifying words that were being used, depending on the certainty of the evidence. But again, the next part is how large is your effect? And as an author, would need to make some sort of judgment about whether it's a large effect, a moderate effect, a small effect, or something that's trivial and or no effect. And depending on the size of the effect, you would also use some qualifying words. So if it's a large effect, you would say, the intervention results in a large reduction in this outcome. If it's a small effect that you found, you would say that this intervention reduces the outcome slightly. And if it's something that's not trivial, it's not important, there's no effect, you would say that the intervention results in little to no difference in the outcome. And a little controversial, we actually said you could say that the intervention does not reduce the outcome. But again, you would still add in, may or probably, etc., depending on the size of the effect. We always are asked then, how do you decide on the size of the effect? And it is a judgment. And we know that authors were doing this before when they were communicating their results. They just weren't being clear or consistent or transparent to readers about that judgment. And I would just say that when you are assessing the certainty of the evidence when you do grade, you do have to come up with these thresholds, as I said before, to even judge imprecision. When you're going to decide what is the size of the effect, again, you're not thinking about the confidence intervals, because that's the certainty of the evidence. What you're thinking about is, where is your best guess from that meta-analysis? The best guess in this case was that there were 10 fewer people. That's the center of the diamond at the end of your systematic review. And that diamond, in this case, landed in between the small and the benefit. So in actuality, this is a small benefit here. It'll be uncertain for sure because it crosses multiple thresholds, but our best guess is that it's a small benefit. In another example, if you found that your diamond lies over here, your best guess is in the threshold or the category of a large benefit. And another example, again, your best guess here is in the part where there's no benefit, that trivial or small no benefit category. And so that's how you would choose in this part, where is the large, moderate, small, or trivial effect, based on where it lands in your thresholds that you would have used when you had graded the certainty of the evidence. So maybe I'll just do this example, and then we can really open it up to some questions. I'll take this example of the heparin versus the placebo and the outcome of bleeds. We have this estimate of 1.34, confidence interval 0.84 to 2.14. If we convert this to actual absolute numbers, so instead of just focusing on the relative risk, we actually say, what does this mean? How many people will actually have a bleed? We would say we had low certainty evidence when we graded the evidence for this risk ratio of 1.34, and it would result in 13 more bleeds if you take the heparin, so just converting it to absolute numbers. Then we would need to determine how big is that 13 more bleeds. What did we assess that out? What was our threshold for trivial, small, moderate, or large effects? Well, if it was 20 more bleeds, we would say that that was a moderate effect. If it was less than 5 bleeds, we would say that it was trivial and really represented no difference at all. But because it's sitting in between the 20 and the 5, we are actually in our range of a small effect. So we would follow our statements. We have low certainty evidence, so we're in that part of the table. We are now at small important effects, and so these are the suggested ways that we could communicate our results. And so we could say that heparin may result in a slight increase in bleeds. And that's how we would get to that. And then just to say that these results, this way of communicating can be put into your systematic reviews. It could be put into guidelines when you summarize the systematic reviews in your guidelines. It can be put into any type of summary when you're communicating to different groups. We are working on these statements when you do a network meta-analysis or a prognostic review, and even with diagnostic accuracy, and also there's a group working on this for when you do systematic reviews of qualitative studies. And then also it is available if you're using the software Grade Pro to communicate your findings in a summary findings table. It's also available to help you create the statements as well. So I might stop here, and then we can get to some more questions, if that's okay.
Yeah, that sounds great, Nancy. Thank you. Like, the time is flying. It's so interesting.
Oh, that's good.
So we stopped at asking, so I think Aaron at 12:23, we haven't answered his question, so maybe we could start there. Maybe going back a bit, but he asked, I have had the same response from a journal. Is it because editorial oversight doesn't always include a method person?
Yeah, and I think we sort of discussed it. It's you know, different reviewers are using different ways of communicating results, and I think if we can be consistent in our ways of communicating the results, even that is a great standard, because we even noticed in people in systematic reviews would communicate differently, even given the same certainty of evidence and even the same possible effects. So they weren't even being consistent within their own reviews. So I think we can really kind of move forward once we start being just even more standardized within our own reviews.
Definitely. Yeah, that sounds great. And then maybe at 12:28, I'm not sure if you've maybe talked about this already. I find the wording that is encouraged for preparing summary of findings tables using grade a bit confusing. For example, may lead to for moderate certainty versus probably leads to for low certainty. Is there another way to summarize the statement?
Yes, and I think that's what we found was that, as I said, over time, we found that some people were just not comfortable with the wording that we had initially proposed in 2014. And so that's why we did now come up with a few more options to choose from, because people didn't like using probably, and they didn't like using may. So now, for example, in the low certainty evidence, there's an option of saying, the evidence suggests, and so using that word of suggests, which might be a little more, people may prefer that a little bit more than using the word may. And then, for example, for moderate certainty, the option could be to use likely instead of probably. So we did test out, even just to say, this is where we put in, the evidence appears, and where people were really strongly against using that word. So we did experiment with quite a few words to see, what people were comfortable using, and so hopefully we provided enough options that people will be able to use these.
So the next question is about heterogeneity. I think it's probably about clinical heterogeneity and statistical. So what if there is, I guess like a lot of heterogeneity and it's inappropriate to generate the pooled estimates? How could we handle this when we want to make a conclusion?
Yeah, it's a great question, because once you decide that you're not pooling because of heterogeneity, you shouldn't be summarizing it narratively either, because you've decided that the studies are so not similar that you shouldn't be pooling them. So, these statements are to be used to make summary statements. So if you're not going to summarize and synthesize your results, whether statistically or narratively, then you shouldn't be making a summary statement at all. So that's an excellent
a really good point.
Yeah,
definitely.
Yeah. Although, but if you're going to synthesize narratively, because the studies are still similar, it's just you couldn't do it because of the data being available, you would still narratively summarize it, and you still can use these statements to communicate. But once you decide that it's too heterogeneous to synthesize, then you're not synthesizing it narratively, and you're not synthesizing it statistically either. Yeah.
Great, thank you. And then I guess maybe Alan kind of touches on this. He said, sadly, may is not very helpful, as it could also be may not. How does one get around this?
Yeah, so I think that, that's where we saw that some people were not comfortable using the word may, and that's why we went to, the evidence suggests, and then you would choose the direction of what the evidence is suggesting. And if people feel even uncomfortable with that, then we argued that people are probably in the very low certainty of, if people don't even want to communicate that the evidence suggests something, then they must have not assessed their evidence in the right way, and actually they're in the very low certainty. Because at this point, they're not even comfortable communicating even a direction of the effect. Yeah. Yeah, that's a great question.
So, I mean, there's a few comments, but so is it Michelle or Michael? So that's, we did come up with more options. And the reason we came up with more options is because I think it's kind of like you're saying that, the more and more options you provide, the more people think that they can start creating their own options. And then we're just back into the same problem we were before. So I think, we're hoping that with a few more options that people will, stop there and say, yep, we've done, we did the research, we did the surveys, etc. We know that they're understood. Here it is. Here are some options. Please use these. Yeah. Yeah. So actually, just for the recording, Michael had asked more options could lead to more creativity, but which Nancy just answered. So then Aaron asks, an observation, accepting uncertainty will always be a problem with humans. They want cognitive closure. Your work tools are important, helps a great deal. Wondering, however, if the social sciences literature could help. Are there methods that could help people subconsciously cope or make them less likely to fabricate certainty in this absence?
If I'm understanding correctly, I think what I think it is an issue, and when we did our focus groups, even with patients and consumers, and we're doing more work with clinicians in applying even recommendations from guidelines, and there's always this battle or discussion about do we want to really reveal that we are uncertain about the effects we find? And I'm convinced, in discussing that we should be telling people, when we make a decision that you have to wear masks everywhere, that there still is some uncertainty about that evidence. But we've weighed the pros and cons and the benefits and the harms, and it's leading to recommending it or not recommending it. And so I think, we have to be honest. In particular, physicians may not want to communicate that we don't know for sure that this is going to happen to you. But that's where then you get to the point where, just as I did with that example, you have to balance those benefits and harms based on the certainty that we have in those outcomes. So I think it's, there's a lot of literature, I think, about this uncertainty and how do we deal with uncertainty, which is really fascinating. Yeah.
Great. And then Samay asks, how do you decide on the threshold cutoffs in terms of effect size? Sorry if you explained, I missed it.
Yeah, so we are always asked, how do we come up with these effect sizes? And what we're saying is we're not telling you where the cutoffs are or anything, but that you would have to make a decision about those cutoffs and those thresholds. And then the question is, okay, well, how do we find out about that? If you're doing a systematic review, hopefully you have a multidisciplinary team that's working with you where you could decide on, amongst your team, what are the thresholds. You could also look at some literature that's out there about minimally important differences. So differences in scores that are important to patients and to the healthcare providers and even at a population level. So that information is out there. I would just say that people say, oh, I can't make those thresholds. We're just going to make them up. But what was happening before was people were making them up and not communicating that they were indeed making them up. So when you go back and you look at the conclusions that authors are making, they will say, this is a large effect. Well, what were your thresholds? So we know that authors want to do that. They want to quantify what was found in the study, and whether it's a large effect, a moderate effect, or small effect. Before, they just weren't making it very clear, and we need to make that more clear.
Nancy, can you give us maybe an example of a like threshold that would be in the literature that we would know about? Maybe?
Well, I know for quality of life scales, a lot of the VAS scales, so if you went and looked for the minimally important difference for VAS scales from 0 to 100, there's research out there that even 4 points is important to patients. So if you were to make your, this threshold, you would say, okay, a change of -4 is my benefit. Anything greater than -4 is going to be my large benefit. And I could say at -2 that it would be my small benefit. And then anything less than 2 is actually no benefit at all.
Great, yeah. And there is literature, right? So you should be going back to the literature and making that decision based on the literature.
So you can. So sometimes that literature is available, and there's a lot of work going on right now to create a database of all the minimally important differences that have been in the literature. So they're searching the literature and putting them all together. If it's not available, then it's something that your systematic review team can do. If you're working with a guideline panel, they absolutely have to make decisions about what's a large increase or a small effect or whatever. So it is pushing authors to be transparent about what they were already doing before.
Great, yeah.
And also avoiding just saying, oh, it crosses the line of no effect, it must be no effect. I was like, well, no, actually, your best guess is that it's actually a small effect here.
Mm-hmm.
Yeah.
I just want to say that we will continue to record after this. So if Nancy, if you still have time, we can still continue to finish the questions off, like however long it takes.
Sure, that's fine for me. Yeah.
Okay, great. So I think DS asked, was the 20 and 5 cutoffs decided by the group in your example?
Yes, so this was a total hypothetical example, but that is exactly what would happen within your author group. So even making those thresholds just to even assess your evidence as being precise or imprecise, that would happen within your group. Yeah.
And then Candace asks, should size of effects be determined a priori for all outcomes?
Yes, and so we've had some discussion about doing this a priori, but sometimes it will happen that, you may not need to, you could go to all the effort of making all these, small, large benefit, etc. But it may turn out later when you're doing your systematic review that actually these thresholds could be determined when you see your other outcomes. And if you've read any of the literature around grade, we would call that a partially contextualized decision about your thresholds, because you are considering, what are the harms and the actual outcome. And then a fully contextualized is what would happen in a guideline group where they really need to make decisions about, well, if the benefit is this large, how large of a harm are we willing to accept?
Great.
But it's something that could happen a priori or once you get in, you see the evidence and need to decide how fine you need to be. Yeah.
Great. Okay, and then Erin says, do word choices like slight hinder the more shared decision making for patients? For example, an X percentage increase in bleeding might be big for me, but small, worth it for someone else.
Yeah, and so it's absolutely, so it's getting at what I was saying about a contextualized approach or a fully contextualized approach. We're summarizing the information, offering what we thought was large and important. We're hoping that authors are making, intelligent decisions about those, and they are making it clear. So that if we always say that when you do go to discuss with a patient, you're actually having that discussion with them about what are their values, and that's part of the value part. Yeah, absolutely.
Great. Yeah. And then Roa asked, any thoughts on adapting the system to use in systematic reviews of prognostic factors where effect sizes are estimates of associations rather than effects? Particularly, any suggestion for substitutions for language? Thank you.
Yeah, so basically what we've seen and what we've been doing with prognostic reviews is using the same language, except instead of, as you're saying, instead of it being a causal effect, so it reduces this, we're talking about associations, and so, or linked to. So we've actually substituted, these causes for a large association, or a slight association, or no association. So we've substituted those words, and we still use probably, likely, may, because that is the certainty of the evidence. So absolutely, that's a great question, because we're absolutely, and even in network meta-analyses, we're using the same types of wording as well.
Great. And then Qualib asks, does number needed to treat or any of its equivalents factor into the reporting?
Yes. So the NNT, this is when I'm talking about the number needed to treat, this is actually the flip of these absolute effects. So we are mostly talking about these absolute effects, which can easily be then converted to an NNT. And so once you make a decision about, that I'm willing to accept 10 fewer, for example, the NNT would be, what is it, 1 over 10? So you can just easily convert it over, and that's quite easy to do.
Great. And then, sorry if I'm pronouncing people's names wrong. So Tiani Zhang asks, can this idea be generalized to non-parametric tests?
So I'm just kind of wondering what you might mean by that. Yeah, I don't know if you are able to unmute or if you're still on, actually.
Yeah, it'd be great if we can hear from you. Tiani? Could be, yeah, not sure.
Well, so if Jenny, if you're still on and you want to add into the chat, we can get to it at the end too.
Okay, so the next question is, it's a very helpful lecture. The methods help the authors to present the results consistently through a lengthy review, especially for authors whose English is their second. My question is that how you describe the threshold. So maybe we've already talked about that.
Yeah, I think we've covered the threshold, so that's good.
Okay.
And then the next question about a narrative synthesis. Well, I think we need to be clear about why people do narrative syntheses. The reason you do a narrative synthesis is not because there was heterogeneity, because basically you're still doing a synthesis. And you've just said that you can't do a synthesis because the studies are too heterogeneous. So, there's also another chapter in the handbook about how to do syntheses when you don't have enough data to be able to actually do it statistically. But we just have to be careful that once you decide some studies are too heterogeneous, you shouldn't be synthesizing them, period, whether it's narratively or statistically.
Mm-hmm.
Yeah. But
so you can describe them one at a time, right?
One study at a time, yes, yes. So you wouldn't come up with a narrative. You wouldn't come up with a narrative synthesis or a bottom line summary, because then you should have done some sort of narrative synthesis and not just described each study separately. Yeah.
Mm-hmm.
Yeah.
Okay, so let's see. I guess Allison asks, for patients, consider the patient acceptable symptom state, the PASS. So I think you mentioned the VAS scale before.
Oh, yeah, so absolutely. So any scale that you have out there and you actually have some information about a minimally important difference, we would definitely say go to the literature to find out about those differences first. And then if they're not available, then you can actually have the conversation with your systematic review group about what your thresholds would be. So yeah, absolutely.
Okay, maybe that's actually, Allison, are you online? Can you ask your question? Maybe you're talking about a patient outcome, patient preferred outcome. Is that what you're trying to get at? Okay, maybe she's left. So then, Tiani replied. She said, when we don't have an estimate on effects. So maybe she means when you're not pooling the studies together when they're too heterogeneous.
Yeah, and so I think we've kind of covered that. If you don't have an effect and you don't even have a narrative synthesis, then you wouldn't use any summary statements because you wouldn't have a synthesis. You would just have each individual study reported separately.
Mm-hmm.
Yeah.
Great. So does anybody else online have any questions they want to ask in person?
I have a question.
Go ahead.
I am wondering how much the p-value is important, because in the hypothetical example, it was almost twice the significance level that I always look for. So like it was 0.1. So I am wondering if it's not important. So when we use it.
Yeah, it's really something that, as you said, even from the, the American Statistical Association, from the work that's coming and being published in Nature, the work that we had from Doug Altman, really the p-value is not turning out to be something that you would use to help interpret your evidence and communicate a result. Basically, we're looking at what we need to do instead is looking at that confidence interval and making a decision about whether that confidence interval is including too many thresholds or cutoffs, and now we just have lower certainty, which is kind of pointing to confidence intervals, because it is an indicator of how certain we are in the effects. And that's where we need to consider it. It's not about how big the effect is, whether it's no effect or not. It's just an indicator of our confidence in that point estimate there.
Thanks a lot. Can I ask another question?
Sure.
About the same example that you brought, the final interpretation was kind of low certainty. Implied low certainty about the evidence. So is it about the confidence interval? It was mentioned based on the confidence interval that we said it is low certainty.
No, and I just use that as a hypothetical example. So, perhaps in this one low certainty evidence, it might have been because they rated down and they had some concern with imprecision, the number of people in the study, and the confidence intervals. And they may have also had some concern about how well the studies were conducted. Or it could have been about publication bias. So any of those grade criteria, I didn't indicate what it was, but they would have gone through all of those criteria for grade to determine a low certainty in the evidence. Yeah.
Thank you very much.
Good. Okay, thanks.
Anybody else? Oh, go ahead.
I just saw that if it's Michelle that he did say, this p-value, is it only applicable to reviews or also to randomized control trials? I think from what's coming out of the Nature and the American Statistical Association, it's for all work. It's for prognostic studies, individual studies of prognosis. People are making they're making conclusions about an odds ratio, and they're saying, oh, there's no association, even though the point estimate of the odds ratio is 10 times. It's just they didn't have a lot of certainty. The confidence intervals were too wide, and maybe it's because there were 3 events, and that's why they have uncertainty. But it really is applying to all types of studies and reviews, whether it's prognosis, prevalence studies, cause and effect studies, or typical intervention studies. It really is something in total about these p-values in general. Yeah.
Great. Anybody else? If not, I would really like to thank you. We had such great participant engagement.
Questions. Yes, great questions. Yeah.
That's awesome.
Good.
Yeah.